Next speaker is Val Lewington. As you can see, the role of nuclear medicine in NETs and an overview. And I certainly picked up, I think, Ashley, with you'll emphasise, and I know Christos will and Val will be, that imagery is improving dramatically. And I think that's one of the main developments that we've seen as a support group over the number of years, that's improving.
Nuclear medicine. It's not a great name, is it? It has all sorts of adverse connotations. Most of them unfavourable, most of them inaccurate and unfair. So the reason for me coming along here today is to explain to you what nuclear medicine is. If you or someone you know has a neuroendocrine tumour, it is very likely that at some stage you're going to be referred to a nuclear medicine department for some scans or maybe some treatment. So what I'd like to do is just take you through what we do, explain and dispel some of the concerns you might have. And if at any stage you want to heckle or wave your arm or interrupt, just feel free, you go ahead. The two critical parts of any nuclear medicine test are that we have these medicines, drugs or clever molecules that have been designed specifically to target the area of interest. So for neuroendocrine tumours, we have specific drugs that will recognise and latch onto the tumour wherever it is in the body. And to that carrier molecule, we add a radioactive tag so that when we give the drug into the body, we can see where it goes to. And the advantages of this particular approach is that these tests are very sensitive. We can pick up tiny abnormalities, and we have the ability to look at the whole of the body in just one examination. So that's a huge advantage when we're dealing with malignant tumours. The downside, though, is that we don't get the fabulous anatomy and the anatomical detail that you get with other types of scans, such as CT or MRI. And so these tests are not competitive, they're complementary. And nowadays what we tend to do is to combine our nuclear medicine images and superimpose them on a CT or an MRI so that we get the best of both worlds. We get the functional nuclear medicine picture that tells us how the tumour's working, and then we can superimpose that upon the underlying anatomical picture. So the critical step is to identify the right drugs that will target neuroendocrine tumours. And we've got two ways of doing that. We can either look at something to do with the metabolism of the tumour, how it's actually working, or we can target receptors that are overexpressed on the tumour, so there's more of them on a tumour than on normal parts of the body. If we look at metabolism first, the drug we know most about is called MIBG. That's sorry, I'm turning into a noddy dog here. It's going to look dreadful on YouTube. Anyway, you're going to think I've got a twitch. Right. So it's this drug called MIBG, which is meta-iodobenzalguanidine. And if I point to this, this is the clever molecule. It's actually quite a small molecule. And chemically, it's very similar to adrenaline or noradrenaline. So it has a natural affinity for the adrenal glands, for tumours that have come from the adrenal glands, and for some, but not all, neuroendocrine tumours that share a sort of similar genetic heritage. And this is a normal MIBG scan. So we're looking at this patient from the front, from top to toe, and it normally goes to the nose, to the salivary glands around the face, to the liver, and then any medicine the body doesn't need comes out in the urine when you go for a pee, so we'll always see a little bit of activity in the bladder, and that's a normal scan. Next. This is an example of a patient who's got a tumour in their adrenal gland. So we're looking here from behind this time. That's the normal bladder there, but we're looking at this discrete focus of very intense abnormal activity. We know that that's where the adrenal gland is, so that gives us our diagnosis. Another patient, here similarly with a tumour arising in or close to the adrenal gland, but then you'll also notice there's a couple of other little spots here in the spine, and another one in the top of the thigh bone. So this is a more advanced tumour. But I think by showing you these two little dots here, you can get some sort of feel for how sensitive these techniques are in picking up really very small volume abnormalities. Now, I mentioned that we might want a bit more anatomical detail. For example, this patient, you should be getting good at this by now, okay? I'll be asking questions later. This patient has got a little spot of bother there in the tummy, and if you can see from the back, there's another little one up there, just sort of in the spine. But it will be incredibly useful to know exactly where these abnormalities are. So now we're going to fuse the images with the anatomical CT scan. So, for example, this one here in the tummy, we've got a CT scan showing some sort of mass there, but we don't know what it is. And in fact, the hot spot corresponds to a tiny part of that mass in the tummy. And all the rest of that is actually normal bowel surrounding and enveloping and sitting on top of the tumour. And then again in the spine, this tiny little spot we saw up there corresponds to a tiny little lesion here, just as the rib joins onto the backbone. And that really matters, because potentially we have very small volume disease. If we can tell a surgeon accurately where to look, this tumour could be resected, it could be chopped out, and this patient could be cured. So it's the fusion imaging that's absolutely vital to managing patients like this well. Now, the other approach to targeting, which is perhaps one we're using more and more nowadays, is to target receptors that are overexpressed on the tumour surface. The one we know most about is somatostatin, and many of you will know about somatostatin analogues. That's the drugs called octreotide, or sandostatin, or lanreotide, all in the same family of medicines that target these receptors. And we can look down the microscope and prove that the tumour expresses these receptors. But then we can put a radioactive tag onto our octreotide and see where it goes to. So this is a normal octreotide scan. Again, looking from the front, top to toe. That's the thyroid gland in the neck. We always see that. Normal liver, normal spleen, normal kidney, quite a lot of bowel, because this stuff comes out in the bowel, and a bit of bladder again. Now, on the basis that you can always complicate an otherwise very straightforward approach, we now have a whole range of different somatostatin analogues that we can use, that we can radiolabel, and that also are available for treatment. Speaking to a UK audience, really in the UK we're focusing very much on octreotide. It's the drug that is most widely available, and the octreotide scan is the one we use commonly in clinical practice, but there are others. So, on your right here, we have a picture taken from a patient who's got a metastatic neuroendocrine tumour. Metastatic means it's spread beyond the site where it originally started and has spread into the liver. You can see these spots in the liver, and a tiny little gland up there in the neck as well. This bit is normal bowel and normal kidney just there. So if your doctor refers you for a nuclear medicine scan, what have you got to go through? Well, you're going to have an injection of the radioactive medicine into your vein, usually in your arm or your hand. And then we'll do a scan with a gamma camera, which is a machine that looks a bit like this. So you've got the patient lying down on a bed, and you've got a camera above and below, and it generally gradually moves up the body so that we can get that whole body picture. It's not claustrophobic. It's a relatively open way of getting these images. And we'll produce a scan like that, like some of the others I've shown you, top to toe sweep. And in this person, you can see that there are lots of spots of increased abnormal uptake in the liver. In order to get that anatomical information I mentioned to you earlier, we're going to then process the images in lots of different planes. So we can look at you sideways, we can chop you up into slices, sort of going horizontally or vertically, etc. And so we can get the very detailed anatomical information with these hotspots that we can see in the liver. We can see exactly where they are in the liver. That's your normal liver there, and these hotspots within it, from all sorts of different directions. So this is looking from behind. This is looking through a sort of trans-abdominal slice. Now, the other sort of nuclear medicine scan you might have heard of is a PET scan, and I know that Christos is going to talk to you about that a little bit later on. The principle is the same, that you have a radioactive drug, but this time the radioactive part is a different sort of isotope. It's called a positron emitter. You need a fancy scanner, a PET-CT scanner, to actually take the pictures with. And this is an example of a gallium PET scan showing multiple hotspots within the liver. That's the bladder, which is normal. Those are the kidneys, which are normal. Now, in the UK, access to this type of PET scan is quite limited. And in fact, this isn't my image. I need to thank one of my colleagues, that's all right, one of my colleagues, Dr. Pamanji from University College Hospital, London, who's very kindly given me this scan to show you today. So when your doctor is referring you for a scan, what does he actually want to know? What are the questions that nuclear medicine scans can help to answer that's going to help him or her to help you? Well, the first thing is we need to know where the tumour originally came from. Many of you may realise that patients with neuroendocrine tumours present quite late. Often you don't get many symptoms until the tumour has spread beyond the original site where it developed and has spread to other parts of the body. But it can still be very important to know where it started from. So this is a CT scan of a patient. We're looking through the liver here. That's the spine. Those are the ribs going around. And this is the liver. And within the liver you can see lots of areas where it's kind of less grey, if you like. And those are tumour deposits within the liver. But we looked everywhere and we couldn't find out where this tumour had originated from until we did the octreotide scan. And you can see here that you have multiple areas of abnormal uptake of our octreotide within the liver, which matches exactly what we'd expect to see on the CT scan. But in addition, there's this tiny little spot down here. It's arising in the bowel quite close to the appendix, and that's where it all started from. Now that matters because tumours that start in the bowel, particularly in that area of the small bowel, can sometimes cause obstruction. They can cause no end of trouble as far as the bowel's concerned. And whatever else you do for the patient, you might still want to think about chopping that tumour out because you can avoid a whole load of long-term problems. This is another example of a patient who presented with symptoms of a neuroendocrine tumour, and there were no other tests that could identify where the problem had started from. This is looking from the front. We've got normal liver, normal bowel, and then this solitary spot, which is where the original primary tumour was, sitting there in completely the opposite side of the abdomen. And this had eluded diagnosis by countless other tests, with scopes and telescopes and cameras in every possible orifice. So this patient then went to surgery. It was removed. The patient is cured. It's never come back. It's absolutely vital to be able to localise these tumours well and accurately so that the surgeons can then move in and sort it out. Now, the other question that's sometimes very important is to stage these tumours very accurately. And here we've got a patient in whom we knew there were multiple spots of bother within the liver, and that had been shown beautifully on a CT scan and again on an MRI scan. But what we didn't know was that there was another tiny little spot there in the bone. That's actually in the hip bone, and one up there just above the liver, just at the bottom of the breastbone. And that has a huge impact on how we might manage this patient. It isn't local disease confined to the liver. The tumour has spread elsewhere. You need to know that in advance. Another example, this is an MIBG scan of a lady who'd had a tumour originating in her adrenal gland, and she was still getting a lot of symptoms. The adrenal gland had been chopped out, and we had no idea where it was coming from. And you see here that this is the MIBG scan. It's normal pretty much everywhere until you get down to her leg. Next, please. And again. And she has 2 tiny little spots of tumour in the thigh bone, in the leg, and we can see that again on the MRI scan. Now, with all the other imaging that we do, normally you'd focus on the abdomen or you'd focus on the chest. You would never in a million years think of going down to look at the legs. But because the nuclear medicine scan can look at the whole body, you're getting added information for the cost of a single procedure. It can be very difficult in neuroendocrine tumours to assess how you're responding to a treatment. Neuroendocrine tumours tend to stay fairly stable in terms of size. When we're evaluating cancer treatments, usually we look to see the tumour shrink. And CT scans and MRI scans are fantastic for that. But with neuroendocrine tumours, often you don't get much of a change in size over a long period of time. So how do you know your treatment's working? How do you know if you're on the right track, or whether perhaps it would be sensible to change course? But if we look at the way the tumour is behaving, the way it's functioning, your Optic Scan can give that particular answer. So this is a patient who has multiple spots of trouble throughout the tummy cavity, tiny little dots spread around all over the place. And his MRI scan and his CT scans didn't change in response to treatment. And we didn't know whether or not to continue with the course that we were following already, or whether we should change. But the follow-up Optic Scan shows that pretty much, not entirely, but pretty much the tumour has been switched off. This is a fabulous clinical response to the treatment. The patient is absolutely having the right drug and they should continue. And you can't get that information from the other sorts of tests that we would normally use. And finally, the other reason for doing these scans is so that we can select patients appropriately who might be candidates for the sort of high-activity radionuclide therapy that we also do. So going back to the original slides, we've got our carrier molecule, which we know will go where we want it to, and our radioactive tag up to now has been using isotopes that are good for doing scans with. But with a bit of chemistry, understating that, it's quite a lot of chemistry, but anyway, but with a bit of chemistry, we can swap the isotope. And instead of using one that we use for imaging, we can substitute in a different sort of isotope that will actually deliver a local dose of radiotherapy. So different isotopes of iodine, yttrium, and lutetium that you may have heard of. The advantages of this approach are firstly that we know we have treatments that will work throughout the body. It doesn't matter if the trouble is in your big toe or the elbow. We know that the tumour will recognise the medicine. It will latch onto one site, 50 sites, 100 sites, doesn't matter. So we can treat multiple tumour sites simultaneously. But that because our drug is specific, so it's only going to go pretty much where we want it to, we will have far fewer side effects than other types of cancer treatment that you may be more familiar with, that are much less specific. And the bit that distinguishes the radioactive treatment from other drugs is that it does go some way to overcoming problems with poor tumour blood flow. As a tumour begins to grow, there's a risk that it may begin to outstrip its own blood supply, which means that if you're giving drugs that are carried in the bloodstream to the tumour, it's very difficult to get an even distribution within the tumour mass. So very often, the best we can do is to get our drug to the outside edge of a tumour. But there are bits in the middle that may still be viable, but are beyond our reach. But if we make our drug radioactive, and we select a radioisotope that has got enough energy to stretch over the whole of this tumour cluster, then very gradually, over a long period of time, we'll begin to build up a lethal radiation dose within the tumour, bringing cells that previously were outside our range, within the range of the tumour treatment. And that's the difference between a radioactive drug and a non-radioactive one. And it is particularly important for neuroendocrine tumours, which can grow to quite a size. So, how do we decide if it's a good idea for you or for someone whom you know? The best treatment for any neuroendocrine tumour will always be surgery. If you can remove the tumour or you can debulk the tumour, you're going to improve the patient's outlook. So we're only looking at treating patients for whom surgery is not an option, either because technically, geographically, it's difficult, or because the tumour has already spread to other parts of the body. Many of you will know that neuroendocrine tumours change very slowly over a long period of time. Some of you will have had tumours for years without really knowing much about it. So if you're minding your own business, if your tumour's minding its own business, we don't particularly want to intervene and rock the boat. We're only going to want to treat patients who have progressive disease, either in terms of getting more symptoms, or the chemistry, the markers, the hormones start to rise, or there's clear evidence on scanning that the tumour's getting worse. And what we have to do is a diagnostic scan so that we have proof of principle that our drug knows where to go to and that we'll be able to get a much higher dose to the tumour than to normal parts of the body. So, for example, this is a patient who's got a primary tumour in the pancreas gland there, which is spread into the liver. And this is a higher power view of the same thing. We can quantify how much of our medicine goes to the tumour, next one, by comparison with, say, normal tissues like the kidneys, next, or to the normal liver. And we can then work out and predict what sort of radiation dose the tumour is going to get compared with what the collateral damage to normal parts of the body might be. I'll come on to the side effects of these treatments in a minute, but we need to know that you've got a good blood count before we start. We need to know that your kidneys are working well, because any of the medicine the body doesn't need is going to be cleared from the body through the kidneys. If the kidneys aren't working well, the medicine will hang around for too long, and you might then get more side effects. Now, the other thing about nuclear medicine treatments is radiation protection. And those of you of a certain age in the UK will remember the Ready-Brek adverts from the 1970s. Okay? These treatments will not make you glow in the dark. You won't light up the room and etc. But because the treatment is radioactive, because you would be radioactive afterwards, there is some sensible precautions that we need to think about in advance. You need to be reasonably self-caring, so the nurses don't get a very high dose from being with you all the time. You will be kept in isolation for a day or two, depending on which particular medicine we use. And after you've had your treatment, we'll advise you to limit your contact, close contact with children or anybody who might be pregnant for a few days. So what are we trying to achieve with these treatments? Firstly, my top priority is to get you feeling better, to control the symptoms by interfering with the way that the tumour makes hormones that are driving the symptoms. We would like to be able to stop the tumour dead in its tracks, stop it progressing, stop it spreading anywhere else. And in some people, we can hope to make the tumour shrink back, but not everyone. It's incredibly variable, and it's often very delayed. It can take months and months to see any change in tumour size. That's not a factor of this particular treatment, it's a function of the way that neuroendocrine tumours behave. Just a few examples for you. This is an example of a patient who was treated with 2 courses of yttrium labelled Dotatok. Dotatok is a variation of octreotide. It's the one we use for the treatment. And you can see before treatment, this patient his primary tumour was in the bowel, and that was removed. But he had a lot of problems with abnormal glands going up and down the tummy, and lots of spots of bother in the bones. And you can see that after 2 treatments, pretty much it had cleared. We had switched the tumour off. So in terms of our objectives, yes, he felt better because it wasn't making hormones. It was well controlled, and in fact, it had begun to shrink back. Next. But most of the time, he was an exception. Most of the time, we're looking at a partial response. This is much more typical of the sorts of responses we see. This is a patient who had 4 cycles of lutetium therapy. You can see, this is again looking from the front, top to toe, before and after. You can see lots of spots of disease in the liver, and you can see them again after treatment. Now, the patient felt tremendously better. All the hormone symptoms went. There is certainly no new abnormal spots, no new hot spots on the post-treatment scan by comparison with the earlier one. So we know the tumour is well controlled. But did it significantly shrink? Not really. With the eye of faith, you may say, well, it looks a little bit smaller, but really that's not good enough. That doesn't count as tumour shrinkage. But it was still a valuable treatment for this particular patient. So what do you have to pay in terms of side effects? What's the cost to get this sort of response? Well, initially, within the first 24, 48 hours, you might feel quite tired, a bit queasy, maybe. You might get some discomfort in the tumour, and we know about all of that, and will anticipate it and treat appropriately. At about 4 to 6 weeks, we would expect to see a fall in the blood count. The medicine's going round in the bloodstream. There will be some damage to the bone marrow. So that might make you anemic, or perhaps more prone to infection, or make you more likely to get some bruising. And that's temporary, and it will recover over the next 3 to 4 weeks. The one we worry most about is a long-term side effect in terms of the dose of radiation to the kidney and the effect of that on the kidney. Because the kidney is getting rid of all of the medicine from the body, pretty much, it will get a dose of radiation, and that can be limiting. So if you come in for this treatment, we get you connected up to all sorts of drips. We have lots of fluids going to keep the kidneys busy to try to reduce that risk. We can't avoid it completely. So where are we now? Well, I think we have excellent palliative treatments for multi-site neuroendocrine disease. I think the treatments I've described to you will give lasting symptom control and long-term disease control. And you might argue that if the tumour is sitting there, but you'll feel fine, and it's not progressing, it's just dormant, minding its own business, actually that's pretty good. Is it good enough? No. We've got to get it better than this. We need to find ways of improving the effectiveness of the treatment. We need to be able to select patients better so we can pick out those patients in advance who are most likely to get the fantastic responses. And if patients are unlikely to benefit, we need to say so, because there are many other new drugs coming along that we've heard about today. We have tended to use this treatment in isolation, and it is probable that if we combine radioisotope treatment with other new drugs coming along, that we might get an additive effect. It's terribly difficult when we have so many options available to us to sequence different options in the right order, tailored to an individual person and to the way that their tumour is behaving. We need to be absolutely clear, it's absolutely vital that we approach these treatments in a very individual way, that it's a one-to-one discussion in order to come up with a plan that suits you or someone close to you. And finally, I hope I've shown you that it's the imaging that is absolutely critical to making good decisions. It may well be that there are different imaging techniques that are most useful at different time points in the whole of the history of this disease. But above all, we want to be able to use imaging so that we can predict response better, so that we can select patients better, so that you will benefit. Thank you. So finally, what is nuclear medicine in terms of neuroendocrine tumours? It's targeted imaging, it's targeted therapy, and I think it is absolutely vital to managing people like you in the future. Thank you.